Well, thank you very much. It's a pleasure to be back in India and my second visit to this excellent conference. Now, I've been coming to India for 35 years, and I'm a clinician, and the key thing about medicine is to observe. And a seminal observation I've made today is this is the first time in 35 years that I've started to talk ahead of schedule in your country. So that's a first for this meeting. So we'll ignore the timer because we've got an hour to spare. So for the next 3 hours, I'll try and entertain you. As you know, complications affect all parts of the body in diabetes. This pointer doesn't work. So the microvascular complications are all silent in their early stages, and they may have no symptoms whatsoever. The power of screening is demonstrated in retinopathy from the UK, where at the top left there, you see that diabetic neuropathy is no longer the leading cause of blindness in our country as it used to be. Why is that? Well, a few years ago, they instituted a national diabetic retinopathy screening program. And all patients with diabetes once a year get a letter, and they go to their local optician and have a retinal non-mydriatic photograph. This is read centrally, and anybody with any worrying features is referred immediately to an ophthalmologist. This screening program has taken blindness off the #1 cause of diabetes. So that's the evidence for you. Kidney disease is silent until it's very advanced if you don't look for it. And the same is true of diabetic neuropathy. And you've heard today about potential screening tools. I'm going to start with a case history that I reported in the British Medical Journal in 1984. And this was when I was working in Miami as a young assistant professor, with black hair, by the way, in those days. And this patient was sent to me. And the key message here is the importance of a good history and a good clinical examination, which is still true today. This patient was sent to me, and he said he woke up one morning and he had a bulge in his side, which you can clearly see on the right side of his abdomen there. But what had happened beforehand, he'd been to his GP, primary care, and he said, I woke up, doctor, I've got a bulge in my side. So without examining him, he said it's likely to be a hernia. He sent it to a surgeon. And the surgeon had a look at him and he said, oh, this doesn't really look like a hernia, so I'll admit you to hospital. Green is a powerful tool. So he admitted this guy to hospital. And for the next 4 days, he was seen by numerous specialists. None of them could decide what the cause of this was. He had a full GI series, intravenous urography, endoscopy in both ends, and everything was normal. So then they said, oh, this guy has diabetes. We'll ask the diabetes people if they can explain this. So he was sent to me eventually after tens of thousands of worth of dollars wasted tests. So I asked him, age and how long have you had diabetes? 10 years. Any complications? No. And what happened here? Well, he woke up in the morning with a bulge in his side. I said, any unusual feelings or any symptoms? He said, well, as you mention it, when I was lying on my right side, it was a bit uncomfortable. The skin was burning, so I lay on my left side. So the next thing is you do a clinical examination. He had reduced sensation in some of the dermatomes here. He had absent abdominal reflexes on the right-hand side. So I thought that this was an unusual presentation of a diabetic thoracic polyradicular neuropathy, which usually presents as pain. But in this case, it presented with muscle weakness leading to this bulge. One test, electromyography, showed abnormal fibrillations in the rectus abdominis and various other abnormalities. So the diagnosis was made. And yet, without taking a history in an examination, others had missed it completely. So the history and examination remains very important in the 21st century as we now are in. Now, as you've been hearing, diabetic neuropathy is a dying back. Gentlemen over there, you can switch the clock off. So it's a dying back phenomenon. Obviously, they can't switch the clock off, but there we are. I don't know how to say that in Hindi, I'm afraid. I apologize. I'm Mahati. So this is a dying back phenomenon, and somebody asked about the upper limb. The upper limbs can be involved, but it's pretty rare, and there aren't any studies of biesthesiometry in the upper limb. Symptoms may be present, but usually there is preserved vibration perception in the upper limb. So the longest nerves are affected, and it can be a feature of being very tall. But of course, there are many other contributory factors. So the Netherlands, which is the tallest race in the world, in Holland, they don't all have diabetic neuropathy, because other factors are important too. But length and height is important. It's common. Here's a study from the Northwest Diabetes Foot Care Study, which we did in the UK. This is a community-based study of more than 15,000 patients around the Manchester area. And neuropathy was assessed using simplified, a composite score from clinical examination, neuropathy disability, and a symptom score. We showed that about 1 in 3 in this community study had symptomatic diabetic peripheral neuropathy, and about 1 in 5 had significant symptoms and signs. In older populations, diabetic neuropathy is more common, and in a separate study, we've shown that neuropathy is present in up to 50% of older type 2 diabetic patients. And we also showed in this study that diabetic neuropathy is more common actually in type 2 diabetes. So the clinical consequences of diabetic neuropathy are summarized in this slide here. Here's the patient at one side who's got severe neuropathic symptoms. They're very difficult to describe pain that has never been experienced before. We've all had trips, falls, cuts. Some of us have had fractures. That hurts. But this pain is very difficult to describe because it's atypical. So patients have difficulty. Some patients say, my feet are on fire, burning, whereas other patients with the same deficit will say, my feet are freezing. They feel like they're in a block of ice. Other patients may describe increased sensitivity, and allodynia is the clinical sign when you touch somebody, a non-noxious stimulus gives rise to a painful experience. And the pains of neuropathy tends to be worse at night. So these are all the features of diabetic neuropathy. At the other end of the spectrum, you've got the patient, how are your feet? Oh, they're great, thank you very much. And yet you examine them and they can't feel anything. In these patients, foot ulceration is a high risk. At least 50%, even 80% of foot ulcers should be preventable. And the prevalent neuropathic ulcer in this country is due to neuropathy, whereas in Europe and North America, we're seeing more and more neuroischemic ulcers. In the middle, most patients have got some symptoms and some signs. So it should be clear why we need to screen for diabetic neuropathy, because half the patients will have no symptoms at all, and if you don't examine the feet, you will miss it. The annual risk of foot ulceration, we showed in a study published 25 years ago using the biesthesiometer that if your vibration perception is 25 or more, you have a 7-fold increased risk each year of developing a first foot ulcer. We need to screen because it's common, because we can treat painful symptoms, and diabetic neuropathy, as we've shown in a longitudinal study, is a major risk factor for generalized cardiovascular disease. So how should we assess our patient for diabetic neuropathy? We take a history. If they have any classical neuropathic symptoms. We do a clinical examination, most important. Simple tests you've heard in the preceding talks of small and large fiber function using a tuning fork for large fiber dysfunction, pinprick, and temperature for small fiber dysfunction. We don't need to do these in clinical practice. We don't need to do expensive quantitative sensory testing. We don't need to do electrophysiology. Now, I work periodically in Miami, and I'll see patients, and they'll come and see me, and I say, you've got a distal symmetrical polyneuropathy, and then explain to them what those big words mean. And then they said, but I've looked it up on the internet. Surely I need a nerve conduction study. I said, well, if you want one, you can have one. And they'll come back $300 poorer with a piece of paper that says, this patient has a distal symmetrical polyneuropathy, but this test cannot tell you if it's due to diabetes, but it may be. Or I said, well, $300 ago I told you that. But they feel happy because they've had a test. And I'm sure the neurologist feels happy because they've made a bit of money. So really, in clinical practice, you don't need expensive tests. You don't need any biopsy or anything like that. Now, I co-chaired the American Diabetes Association working group on diabetic neuropathy that put out in 2017 the position statement, the revised one. And even in America, I was able to persuade the whole committee, you don't need any of these. You don't need detailed electrophysiology, quantitative sensory testing, etc. If you've got a biaesthesiometer like we do, we use it. It's very useful, but you don't have to have it. Simple clinical tests, history, and exam is all you need. These are the kind of tools you've just seen in the demonstrations in the last hour. Can you feel the vibrating and tuning fork? Tendon reflex, monofilament, just as you've seen. That's all you need. Now, in the next talk, and unfortunately my wife, Dr. Loretta Villikite, was supposed to give the next talk, but she is just recovering from the usual winter illnesses in the UK because it's winter still. Apparently it's winter here, but I'm not quite sure today. And she's done a lot of work on what neuropathy does to quality of life. And she's shown that both positive and negative symptoms pain, negative symptoms, unsteadiness, loss of sensation, numbness, they impact patient function and quality of life. Painful symptoms also generate anxiety. Negative symptoms associated with depression. And pain-related sleep disturbance, of course, will have a negative impact on quality of life. More recently in Manchester, we've been looking at large fiber dysfunction in some detail. We know that diabetic peripheral neuropathy is associated with a huge increase of risk of falls, trips. And we've also confirmed that unsteadiness is a major symptom of neuropathy that's not in the textbooks, at least it wasn't, it will be now. Because patients say, oh, you know, I'm getting a bit older, so I'm a bit unsteady on my feet. We've shown that neuropathy is an independent risk factor for falls. And then, of course, unsteadiness, trips, minor sprains, continuing to walk may be precipitant in the neuropathic foot of Charcot-neuroarthropathy. So here's the relationship between unsteadiness and diabetes. We've shown, as I've said, this is a very common symptom of neuropathy. It's predictive of depressive symptoms. It's the strongest determinant of not following advice to wear an offloading if it's a removable device, such as a cast. The patient says, this is terrible, I can hardly walk, I'm unsteady, so they take it off because the foot doesn't hurt. And we've also shown very recently that patient perception of unsteadiness correlates strongly with lab tests of imbalance. So in Manchester now, working with my colleague Professor Reeves at the Manchester Metropolitan University, he's got one of the best gait labs in the UK. So we can assess walking not only using these force plates here, looking at pressures underneath the feet during standing and walking, but we can also assess balance when patients are coming up or down stairs. And if you think about it, most falls do not occur when you're walking on a carpet like this, but when you're going up and down stairs, particularly if the stairs are shallow and it's dark. Because many patients have lost dark vision because of multiple retinal treatment with laser photocoagulation, and falls occur commonly in the dark. So here's Professor Reeves as a control, and we can tag our patients with reflective markers, and then we can assess their gait and how unsteady they are, how much they sway. We can look at internal joint moment or muscle forces, generation of forces by major muscle groups. But the next, hopefully, which it works today, is a video. On the left-hand side, you'll see a patient with no neuropathy, a control walking downstairs. On the right-hand side, someone with neuropathy. Can someone trigger this to start? Yeah, here we are. Here's the non-diabetic patient. But look at this. Much more sway, much more unsteadiness, variation from the mean. You see there anterior posteriorly, but also laterally. You look again, that's a non-diabetic. Look at the difference from the diabetic neuropathic patient here. Splaying of the feet, slow gait, more sway, AP and medial laterally. So that's unsteadiness. Now, what are we going to do with someone who presents with distal symmetrical polyneuropathy, the commonest form of diabetic neuropathy? Well, as you know, they may have painful symptoms, they may have deficits, that's reduced sensation to large and small fiber function on examination. This leads to impairment, disability, handicap, reduces quality of life. Of course, those with loss of pain and large fiber dysfunction are at risk of foot ulcers. But foot ulcers don't occur spontaneously in the neuropathic foot. Foot ulcers only occur if there's neuropathy plus something else, such as walking barefoot, walking on a foreign body, recurrent walking on calluses, and so on. And as you know, foot ulcers may become infected. We've already discussed the Charcot foot. And of course, this might lead to surgery, amputation. And this drives cost. But not only does this drive cost, but so does painful neuropathy. Because patients with painful symptoms have disturbed sleep, they're feeling quite anxious and depressed, and they miss work. What we'd love to have is a drug, and of course mortality is increased in patients with a history of foot ulcers with Charcot, as I'll show later. So we'd love to have an agent, we could call it Agent X, which not only would treat the underlying pathophysiology and perhaps stop the natural history of neuropathy, which is progressive loss of nerve fibers on a distal proximal gradient, but we'd love that agent also to control neuropathic symptoms. We don't yet have this Agent X. So if you like pathogenetic or those treatments that influence the natural history are seen here, and the only one shown to be useful in certainly preventing neuropathy, as we know, is the Diabetes and Control Complications trial in the UK PDS. Stable near normal glycemia will reduce the incidence. Alpha-lipoic acid has some evidence that it might reduce pain in diabetic peripheral neuropathy, but all these others, gamma-linolenic acid, aldose reductase inhibitors, PKC beta inhibitors, nerve growth factors, they've all failed miserably in clinical trials. The first study I did as a fellow back in 1979-80 was looking at sorbinil, an aldose reductase inhibitor. You know, and 40 years later, there's not much on the market that's any good. We showed in a paper in The Lancet a few years ago that ACE inhibition might slow the progression of deficits. In other words, measuring nerve conduction velocity, we showed some improvement. But they're not going to help symptoms. But it may be that ACE inhibitors have a place in early treatment and prevention, not only of retinopathy and nephropathy, but also of neuropathy. What about blood glucose flux? You heard the first talk, Dr. Krishnan mentioned insulin neuritis. We know that acute painful neuropathy can follow periods of metabolic instability or sudden improvement of glycemic control, insulin neuritis. It's not only insulin. It's been reported, for example, with sulfonylureas in the 1950s. We know that painful symptoms will improve with stable near normal glycemia, and more important is the stability than the level. We know in animal models that hyperglycemia reduces pain thresholds, and that's insulin neuritis there. And we've recently reported, because we have a large series of patients undergoing combined simultaneous pancreas kidney transplants, and these patients on dialysis have poor control. Overnight, the pancreas transplant, sudden normalization of blood glucose. And we've reported acute painful neuropathy, which is insulin neuritis in these patients. The good news is it gets better within a year. Now, in an early study in 1982, we showed using the very early syringe driver insulin pump therapy that stable blood glucose control appears to reduce neuropathic pain. 20 years later, we thought we could look at this with the advent of continuous glucose monitoring. So we looked at two groups of patients, both of which had type 1 diabetes, and both of which had moderate neuropathy on examination. Half of them were asymptomatic, and half of them had classical severe neuropathic pain. So we used the MiniMed, now Medtronic continuous glucose monitor, and looked at blood glucose instability or flux in those with painful and painless neuropathy. And that's the old-fashioned, the very early CGM in this study. This is a patient's 24 hours here of tissue glucose monitoring using the Medtronic device. And the block squares here are patient's self-blood glucose monitoring. First of all, you can see that the agreement here is very good. But secondly, you can see this is in millimoles, so that's 180 millimoles, that's 90, that's 270. And you can see overall this patient's control is stable, could be better, but it's not too bad. The next slide is from an example of a patient with quite severe painful neuropathy, and you see immediate difference. Much more blood glucose flux, higher readings. And what we showed in this study, those with painful neuropathy had overall worse glycemic control, more sways to hyper and hypoglycemia, and using the M value, which was first described by John Service in Rochester, the Mayo Clinic, many years ago. This is a measure of excursion from the mean. The M value was twice as high in those with painful neuropathy than those with painless. And glycemic excursions were greater. So this shows that patients with painful neuropathy have overall worse control, but more importantly, much more swings. And we believe that this unstable instability of blood glucose control may lead to neuropathic pain, perhaps by stimulating nociceptive afferents or neuroma-like effect, that biochemical changes leading to firing of C fibers that carry pain perception. So patients with painful neuropathy have poorer glycemic control, higher mean blood glucose, and much more instability. Also, we showed more hypoglycemia. So when you come to your patient, what are you going to do? Here's someone who has painful neuropathy. What am I going to do? Well, first of all, there is no test, not even electrophysiology, will tell you that the neuropathy in your patient is due to diabetes. None at all. So we need to exclude other causes of neuropathy, of which there are many. But perhaps most important would be paraneoplastic syndrome that can present as painful neuropathy. Toxins, alcohol, too much alcohol is probably more than your doctor drinks, so that's a good definition. But the studies appropriately came for Edinburgh, where they like Scotch whiskey, and of course alcohol can cause neuropathy, but in quite high doses. There are many other toxins, iatrogenic. Many of the drugs we use, for example, in malignant diseases, cisplatin, the vinca alkaloids used for lymphoma. I've got a couple of colleagues who've got they've been treated for lymphoma, and they've got terrible dysfunction now with a severe neuropathy. But of course, the risk-benefit ratio, their cancer's gone, but they're left with a side effect. Drugs used, for example, isoniazid or some antibiotics can cause. And other diseases, I didn't put here, but of course in this country, Hansen's disease was very prevalent some years ago, and there are still cases here. And we learned how to look after the diabetic foot from people like Dr. Paul Brand and colleagues in CMC Vellore and Kadagiri. So we've learned a lot from how to look after the diabetic foot, from how to look after the foot in leprosy. After that, obviously, we need to assess the level and stability of control and address that. An explanation. Doctors are hopeless at telling patients what neuropathy is, and patients get very angry. Most patients will need some form of pharmacotherapy, and non-steroidal drugs are pretty hopeless. One small trial years ago of one Solindac. But remember, most patients, or many patients with neuropathy, will also have some diabetic nephropathy, in which case these drugs are contraindicated. So there's little evidence to support the use of non-steroidals. The tricyclic drugs, especially amitriptyline, are well proven, and they're very helpful in relieving neuropathic pain if the patient can tolerate them. They've been supported by multiple RCTs and meta-analyses. But, there's always a but, adverse events are predictable and frequent. Up to a third of patients can't even tolerate the lowest dose, say 10 milligrams of amitriptyline. So this is resulted by their replacement, in many cases, by other drugs that have come out in the last 20 years or so, including gabapentin, pregabalin, tramadol, oxycodone, duloxetine. Gabapentin, useful drug. Its efficacy is similar to amitriptyline, but fewer side effects. But no drug is without side effects. Its efficacy in diabetic neuropathy proven in more than one trial. The problem with this is you need a high dose. The mean dose on the clinical trials is between 1.5 and 2 grams a day. And yet I see patients coming in, well, I'm on 300 milligrams at night. You might as well take an aspirin. Actually, aspirin might be better. And it's 3 times a day. We burden our patients with many drugs, and 3 times a day is not great. So later came the distant cousin of gabapentin, which is pregabalin. Also, it's used in complex partial epilepsy. But this is a pooled analysis by my good friend Roy Freeman from Harvard. He has looked at all the trials, of which there have been many, and showed that the drug is efficacious in relieving neuropathic pain, and it's dose-related. Now, I know in India that the doses used of drugs such as amitriptyline and pregabalin are lower than in Europe. It's the same with pioglitazone, for example. We tend to use 30 to 40 milligrams, and you use 15. So lower doses, the average dose in the UK is about 150 milligrams BID, but in this country it's often 75 milligrams. You can use up to 300 twice daily. This is a twice daily dosage. All these drugs have side effects. Then we have duloxetine, which is a combined 5-hydroxytryptamine or serotonin and noradrenaline, norepinephrine reuptake inhibitor, whose efficacy has been shown in now more than 2 randomized controlled trials. Like pregabalin, it's licensed in Europe and America for diabetic neuropathy. This drug also has an antidepressive effect, of course, and I didn't mention, but pregabalin also has an anxiolytic action. Some patients may need stronger drugs, and there is evidence from randomized controlled trials for other drugs, such as tramadol, an opioid-like drug. It says fewer opioid side effects, but these drugs all have side effects. And many patients will become constipated. Central side effects, just tiredness. And you've got to be careful with using these drugs on a longer period. The trials have been in 6 months. And there's also evidence for controlled-release oxycodone in severe neuropathy, only for short-term use. There is some evidence for some topical treatments, such as the 5% Lidocaine medicated plaster in this study here from Switzerland, but these are not widely available. Now, I trained initially in neurology, then in diabetes, so the question is often asked, whom should I refer to a neurologist? And I would suggest that people in all of these groups, you should think about referring to a neurologist. Diabetic peripheral neuropathy is a symmetrical distal polyneuropathy with predominant sensory symptoms and signs. So if you've got someone who's got asymmetrical neuropathy or predominance of motor signs with rapid progression, if they've got a family history of neuropathy or back or neck pain, especially if you think there might be this rare but treatable chronic inflammatory distal polyneuropathy, CIDP, chronic inflammatory distal polyneuropathy. This is treatable by immunotherapy, and it presents like amyotrophy you heard in the first case in the first lecture this morning. These patients warrant referral because they might sometimes respond to immunotherapy. This was the treatment algorithm we published back in 2010 following the International Toronto meeting on diabetic neuropathies. And this is for painful diabetic neuropathy. First of all, exclude other causes. stabilize diabetes control. And then you can go down this line, you can try an anti-epileptic first or an antidepressant-like drug. I actually call them the tricyclic drugs, not the tricyclic antidepressants, because their action in polyneuropathy is probably not related to depression. If they don't work, you can try the other. You might try combining these, even though the combo trial didn't suggest obvious benefit of combining them. But there's many anecdotal reports that they are useful together and they work in different ways. Then you might want to try, if these all fail, you might want to try a synthetic or a stronger opioid. But this is the panel of the 2017 statement on diabetic neuropathy, co-chaired by my good friend Rodica Popescu, originally from Timișoara in Romania, now professor of diabetes in the University of Michigan, Ann Arbor. And we had 3 neurologists, Roy Freeman, Vera Brill from Toronto, Eva Feldman, and Riaz Malik, my former fellow, Jay Sasenko from Miami, and Dan Ziegler from Düsseldorf. And we put the statement together based upon consensus and evidence-based literature. And from this, we say, is the pain due to diabetic neuropathy confirmed? Yes, assess comorbidities. What's the potential for adverse reactions? And what's the cost? Now, amitriptyline is virtually free. It costs next to nothing. Whereas other drugs are very expensive, and cost, of course, matters. To our health service, it matters a lot, and I know to here as well. So you might want to try the voltage-gated alpha-2 delta ligands, such as pregabalin or gabapentin, just the same, really, or these, or secondary tricyclic. And then you might want to take this pathway. Now, Diabetes Care, I'm the senior associate editor, and have been for 15 years, looking after neuropathy in the foot. You can download all our articles free of charge 6 months after publication, so you can download this if you're interested, free of charge, and look at the advice given.